So Rima emphasized the clinical context, and Ted emphasized the cultural context, and I'm going to go with the yellow group and emphasize the social context, and go with Andrew and say include their whole life. So you should have 3 pages. So the life skills progression instrument. Since you have it in your hand, we'll go ahead and look at the instrument, and then I'll give you 5 reasons why I think it might be a useful model for promoting and monitoring health literacy in chronic disease management. Okay. So this was really beautiful on my Mac, and now it's a little jumbled, so I was told you wouldn't mind. So you've probably already noted by looking at the instrument that the content is specific to maternal health literacy. This is our definition, and it is from Don Nutbeam's group. We looked at maternal health literacy as a life skill that mothers use to manage personal and child health and health care. Now, pregnancy and parenting do not constitute a chronic disease, but you probably all know that they do present a long series of new health and health care challenges and self-management challenges. There's also another link. Chronic conditions, non-communicable conditions, heart disease, lung disease, diabetes, obesity, many cancers, all have origins in early development. So that promoting health literacy in parents and empowering women, those are the same things, are recommended by the World Health Organization as global strategies to reduce the burden of non-communicable diseases and their attendant disparities. Still, it's not the content that's of interest here, it's the approach to promoting and monitoring health literacy skills development that may be useful in our discussions. The author of the LSP is my colleague Linda Wallison. That says .com there at the bottom. Linda wrote the LSP in 1996 as part of a successful $3 million grant application to evaluate the effectiveness of home visitation. Home visiting is a preventive intervention that aims to promote maternal and child health and healthy child development. And she and I have collaborated ever since. The LSP was published by Brooks in 2006, and in 2011, as part of the implementation of the Affordable Care Act, the LSP was recommended for documenting progress to federal benchmarks of effectiveness in home visiting. So you have this copy that you can actually read. And I've given you 4 pages and another document that we'll discuss. The 5th page is child scales and not relevant here, so don't worry about that. And please do not let the length of this document scare you off. It takes an experienced practitioner 5 to 10 minutes to complete the LSP, and it's done at intake every 6 months and at closure. So we're talking about 10 to 20 minutes per person per year. Note that the instrument is not meant to be seen by patients, and it's not an interview form. If you look at the header, let's see if I can point to this. So up there, you see all of the demographic information, so it allows you to sort on all that. In the center there are reminders of upcoming assessments. So this is a longitudinal measure. Here we have months of service and visits. This allows us to begin to figure out what's the dosage, how many visits, how many encounters does it take to affect change. And you'll see on your handout that we use that medical code section to integrate a literacy screen, which was developed by Ian Bennett specifically for use with parents. So that allows us to estimate reading level. Okay. So, in the body of the form, you see it consists of 35 Likert scales. They cover 6 areas of life skills development, and each of the items stands alone, so this can be unbundled. So we have, for example, some programs where there are religious objections to family planning, so we just remove that item. So each of the items on the LSP uses words to characterize progress from dysfunction, that's a score of 1, to optimal functioning, which is a score of 5. So for chronic disease, a score of 1 would probably be what do they look like upon initial diagnosis. The high score of 5 is not necessarily perfect health, but rather as good as it gets with effective management. To score the LSP, the practitioner circles words that apply to this particular patient in the previous 6-month period. This circling of words is an important step that builds reflection into the process, prevents rushes to judgment, and so increases the reliability. The score is derived from the numbers at the top of the column in which circled words apply. So you can have a mixed score like 3.5 or 4.5. Okay. The 0 is an important feature. It's used to indicate not asked, not answered, not applicable, unknown. So this is to prevent guessing, and the 0 is not included in the calculation. Another important scoring concept is target range. The target range indicates adequate to optimal functioning, and it varies by the item. A score in the target range is considered to be a strength upon which to build in order to raise scores that are below target range and indicate a need. So needs show up on the left and strengths are on the right. The number and percent of Persians or patients in target range shows progress by caseload or by patient population, also shows progress to program objectives, and highlights training needs. Now, if you take a look at the color-coded sheet, this is the cumulative score sheet. It's used to facilitate comparison of sequential measures, which shows progress or regression. So here you can see all of the scales listed together, and to the right of the name of the scale is the target range. Okay, so I derived 2 scales from the life skills progression to measure maternal health literacy. The 9 items that you see highlighted in green make up what we call the healthcare literacy scale, and it rates parents' use of information and services for health. The 7 items that are highlighted in yellow make up the self-care literacy scale, which rates management of personal and child health at home. And the target range for the health literacy scales, 2 separate scales, is a combined average score greater than 4. So why do I think this might be useful here? First, note that the LSP was an existing instrument in routine use in programs across the country. So we found in this instrument meaningful measures of maternal health literacy that passed validity testing. So this greatly reduced the cost and the time required for the development of the measure and for training and testing. Data could be gathered quickly and widely. So my point is that we may not need to reinvent the wheel here this week, and that it would be wise of us to look to data that we routinely collect already and to instruments in our fields and related fields and see what we already know and are doing and can use. There are undoubtedly other instruments that you know that you could repurpose to use instead of or in addition to an LSP for chronic disease. Secondly, and perhaps most important, the life skills progression is a progression. It assumes that progress is possible. It expects progress. It makes progress the goal and the measure of success. So this overcomes perhaps the biggest problem with currently used methods that document deficient health literacy by a single assessment with the false assumption that people will not or cannot improve or develop their skills. And that enforces dependence on providers. Further, the LSP assesses multiple skills that are needed to participate in healthcare and self-care. And I do admit that we did mush them all together. So we look at all of these skills in addition to reading skill. So it overcomes another shortcoming of current methods that only estimate reading skill. And the LSP begins to elucidate what is the role of reading in health literacy. Some of you have heard me say this before, focus on function. The LSP focuses on actions, practices, and behaviors rather than on direct skills testing. So it assesses skills development by changes in what people actually do with the information and services and support available to them, so that the LSP captures the effects of both system efforts to improve information and services and other efforts to improve the skills and capacity needed to use those services and information. I think we're on third now. The stated purpose of the LSP is to guide practice, and it makes data-driven practice feasible. It takes evidence-based practice to a new level in which practitioners routinely collect data and use it to improve their own practice and therefore to improve outcomes. The LSP makes data-driven practice possible because the instrument is completed by the practitioner who has a relationship with the patient. So the LSP does require a relationship, which is built through regularly occurring encounters over a period of time. Some people will say we don't have time to develop a relationship. I would argue that for chronic care, you must have a relationship with the patient. This makes the data immediately available to the person who collects it to use for tailoring intervention to particular persons and circumstances. So the approach assumes that by default or by design, practitioners influence the personal, social, and environmental factors that interact to determine a person's health literacy at any given time. I loved hearing people talk about empowerment here today. The LSP addresses the empowerment aspects of health literacy, and this is individual empowerment, which largely is ignored in the literature but is essential to a sustainable, equitable healthcare system and to effective self-management. Promoting health literacy skills is empowering because and to the degree that it enables a person to gain control over their health and its determinants. So the LSP shifts the question from how poorly does this patient read to what can this person do and how can we build on their strengths to enable them to learn and do what else is required to regain and maintain their well-being. Without empowerment, health literacy skills foster dependence on health professionals and defeat long-held systems goals of activated patients and responsible healthcare consumers. So an LSP for chronic disease could facilitate our shift from educating patients in order to improve their knowledge and compliance to empowering persons in order to increase their capacity and their autonomy. And finally, context matters. We've said that before, and I really want to emphasize. Separating patients from the context of their everyday lives and placing them in a controlled situation makes sense when we're treating acute conditions. But when the goal is to improve health literacy or self-management of chronic disease, context is everything. Most health-related information is obtained, understood, and acted on outside the healthcare encounter, particularly at home in trusting relationships. So it's the non-clinical context that determines the health literacy task and the capacity to complete the task and the support that is needed to develop that capacity. From a research standpoint, it makes sense to treat context as background noise when we're doing a clinical trial that wants to isolate the effects of a single factor. But in promoting health literacy, research necessarily aims to find the combination of factors that will be effective in a particular circumstance. And isolating the effects of a single factor, like reading, runs the risk of proving that nothing works. So I want to, these are the key findings of our intervention studies on this approach using the LSP, which I'm very happy to talk to you about at length when we have time. And I just want to finish by showing you this. This web of interaction. We plotted the statistically significant correlations between health literacy indicators and surrounding family conditions, and this is what we got. A few of these are at significance level 0.05, but most of them are 0.01. So this web of interaction, if you weren't convinced, demonstrates that health literacy is massively multifactorial. And if there's anyone here who does path analysis and is intrigued by this, please see me. When this is fully developed, it will guide intervention and show pathways to promoting health literacy. So my final word is that the social context matters. Okay.